Welcome to the deep dive. Today we are tearing into something absolutely foundational for effective healthcare, communication.
Yeah, it's everywhere. As
R-
our source material points out, we're basically communicating all the time. It's kind of a nonstop thing.
You can't not communicate. Even when you're silent, you're still sending some kind of message.
Exactly. And in healthcare, especially in high-stakes situations, understanding that principle, well, it can literally mean the difference between healing and harm.
So true.
Our mission today is a deep dive into therapeutic communication. We're using Chapter 9 of Varcarolis' Foundations of Psychiatric Mental Health Nursing as our guide.
Okay.
We really want to pull out those scientifically based skills that nurses need to build relationships that are patient-centered and, crucially, goal-directed.
Now the stakes here are just huge, aren't they? I mean,
Oh.
we're not just talking about having a nice bedside manner. This is about safety. Communication failures are serious. They can be fatal, actually. When you look at the data, like the source mentions, medical errors contribute to, over 250,000 deaths every year in the
It's
U.S.
staggering.
And poor communication is a huge part of that. It's not just awkwardness, it's a major killer. And something like 30% of malpractice claims, they come from interactions that just went wrong.
Yeah, they just failed. And realizing that, it immediately makes you think, okay, this isn't just casual talk. We need to understand the theory behind therapeutic exchange.
Right. So what is the difference then? What takes it from just talking to communicating with a real professional therapeutic goal in mind?
Well, therapeutic communication, fundamentally, it's patient-centered, it's goal-directed, and it uses defined scientific principles.
Okay.
And I think, crucially, it treats the patient as a full partner in their care. You're prioritizing their preferences, their needs, above everything else.
So unlike just, chatting with a friend.
Exactly. Every word, every pause, it's serving a clinical purpose. Maybe clarifying a symptom, or building trust, or helping promote a behavior change. It's intentional.
Okay, so to really get the mechanism, we need to start with the theory. Let's unpack the transactional model of communication first. It sounds, systematic, but also pretty dynamic.
It is. It's both. The really critical idea in the transactional model is how it defines roles. Both people involved are simultaneously senders and receivers.
Communicators, right?
Communicators, yeah, and they're constantly adapting to each other. What that means is if you, as the nurse, don't genuinely listen and really absorb the message, then according to this model, the communication just stops. It basically never happened, even if you both said words.
Wow. That makes it feel incredibly interdependent. Like both people have to be fully engaged.
Totally.
And the context part.
Yeah.
The source says it's multi-layered. That sounds, frankly, a bit messy for a fast-paced clinical setting. Social rules, relational history, culture. If all that influences everything, how do you actually use the model?
You use it mainly to spot the barriers, that complex context. It's constantly being filtered through what the model calls noise.
And noise isn't just sound.
Right. We think of physical noise like a loud TV or lack of privacy, sure. But there's also physiological noise, like if the patient has a headache or is tired. And then the really tricky one is psychological noise.
Ah, the stuff going on inside someone's head.
Exactly. Worry, anxiety, being preoccupied, that's often the biggest barrier because it affects whether someone is even available to take in information.
So you could be saying all the right things.
Perfectly clear verbal message, yeah. But if the patient is just overwhelmed with that internal psychological noise, boom, communication fails right there.
Okay, so that's the transactional model defining the system. What about Peplau's interpersonal theory? The source says it gives us guiding principles for delivery.
Pepau's great for that. She really zeroes in on two key goals, clarity and continuity.
Clarity and continuity.
Yeah. Clarity means the meaning has to be accurately understood by both people. That needs validation, feedback. You check in.
Makes sense.
And continuity is about connecting the dots, linking the patient's ideas, their feelings, the underlying themes in what they're saying. Peplau's theory is actually like the blueprint for the clarifying techniques we'll get into later.
Oh.
It shows that good communication isn't just, something you pick up. It has structure.
So Peplau teaches us how to be clear. But what about the inevitable human stuff? The internal things that can mess up even the best intentions?
Right. This is where the patient's psychiatric state can become a huge internal barrier. You absolutely have to tailor your communication.
How so?
Well, think about depression. It often causes slowed thinking, right?
Yep.
So response time is reduced. Anxiety, on the other hand, can make concentration incredibly difficult.
In mania.
Mania makes it almost impossible to focus on one topic for more than a few seconds sometimes. These conditions directly impact the patient's ability to function as an effective communicator in that transactional system we talked about.
And then there are the external factors, too. The environment, the relationship dynamics.
Absolutely. Environmental stuff is often pretty obvious. Too much noise, no privacy, uncomfortable seating. But the relationship piece is interesting. The source talks about symmetrical relationships, where people have equal status, like friends or colleagues,
Okay.
and complementary relationships, which have unequal status or power. That's the nurse-patient dynamic, typically. Or teacher-student.
But the inequality isn't always fixed, is it?
No, exactly. In the nurse-patient relationship, it usually starts out complementary, with the nurse having more positional power, I guess. But as the patient recovers and gains autonomy, that inequality often decreases quite a bit.
Okay, let's pivot now to the message itself. Verbal communication, the words. That's the content.
Right.
And nonverbal communication, body language, tone, how fast you talk. That's the process. Why does the source emphasize that the process is often more important?
Because that nonverbal process, that's usually where the real message is hiding. It's much harder to control consciously. So it tends to be a more authentic signal of emotion, intention, how the relationship actually feels. What we're aiming for is congruence.
Meaning the words match the actions.
Exactly. Verbal content matches the nonverbal process. When they don't match, that's incongruence, and it creates ambiguity, confusion. It's a problem.
Which leads to this idea of double-bind messages the source describes. That sounds pretty damaging.
It really is. A double bind happens when someone, usually someone with more power, sends two contradictory messages at the same time. Often one is verbal and seems okay, but the nonverbal one is hurtful or implies the opposite.
The book gives an example, right? The mother and daughter.
Yeah, the vignette is perfect. You have this frail mother who verbally tells her daughter, oh, go on, go out, have fun. But her whole posture, her sad expression, maybe dropping her cane, it screams neediness and pain.
So the daughter is trapped. She's told she can go, but she's hit with this wave of guilt non-verbally. She literally can't win.
Can't win. And all of this communication, verbal and nonverbal, it gets filtered through our own unique cultural filters.
We can't just listen objectively.
Nope. Our background, our upbringing, it dictates what gestures mean to us, what tone of voice feels trustworthy, even how close we stand to someone. If you're not aware of your own filter, you're going to misinterpret things, or maybe even offend your patient without meaning to.
That seems especially critical with nonverbal cues like eye contact and touch. They seem really culturally loaded.
Oh, definitely. Eye contact is maybe one of the most variable. In many Western cultures, direct eye contact means sincerity, trust.
Right, generally.
But in some other cultures, avoiding eye contact is actually a sign of deep respect, especially towards an authority figure. And making direct, sustained eye contact could be seen as aggressive or invasive or even sexually suggestive. It really depends.
And touch has that same kind of complexity.
Absolutely. Touch can be incredibly therapeutic. Just a simple hand on the shoulder can convey warmth, support. But if you ignore cultural norms or if a patient has a history of trauma involving inappropriate touch.
Then it could feel really threatening.
Exactly. Intrusive, aggressive. The text really hammers this home. Nurses have got to be super sensitive here, especially with kids and adolescents. Sometimes a strict no-touch policy might even be necessary, at least initially.
Okay, the stakes are definitely too high to just wing it. So let's get practical. Let's move into the essential skills, the DOs, of therapeutic communication, starting with the surprising one, silence.
Yeah, silence. It's easy to think of it as just nothing, an absence, but it's actually a channel.
A channel for what?
For reflection. It gives both the patient and the nurse a beat to process, to think things through, weigh options, gain some perspective.
But there's a catch, right?
There is.
Yeah.
The caveat is important. Too much silence or silence that isn't managed well can actually be non-therapeutic. It can feel like abandonment or just be really difficult for patients whose thinking is slowed down by depression or schizophrenia, for example.
Okay, so beyond silence, the real cornerstone technique is active listening. How does the source define that? More than just hearing.
Oh, much more. It's about intense focus, responding thoughtfully, and remembering both the verbal and the nonverbal cues. When you really actively listen, you're like a sounding board.
How does that help?
It boosts the patient's self-esteem. They feel genuinely heard, and it strengthens their own ability to solve problems because they're clarifying things for themselves as they talk.
Okay, so we've got silence and active listening. Now let's make Peplau's ideas concrete, those clarifying techniques. They sound kind of similar, but you said they each have a specific job.
They do, yeah. Let's break them down. Paraphrasing, that's when you restate the basic content of what patient said, but in your own words, usually fewer words. It shows you understood the core message.
Okay, like summing it up slightly.
Sort of, yeah. Then there's restating. That's different. You repeat the patient's exact key words.
Why do that?
To confirm you heard accurately,
Hmm.
or to highlight something specific they said. Like the example, patient says, "My life is empty." The nurse might say, "Your life is empty." It encourages them to elaborate on that specific feeling.
Got it. And reflecting and exploring.
Reflecting is about bouncing the feelings or ideas back to the patient.
Yep.
Helps them own those emotions. So something like, "You sound as if you've had many disappointments." That's a reflection on the feeling tone.
Okay.
And exploring is simpler. It's just digging a bit deeper. Tell me more about X, or describe that relationship. You're asking for more detail.
And finally, in the DO's category, let's talk therapeutic questioning. We know open-ended questions are good, but I really like those hypothetical ones the source mentions.
Yeah, the projective questions, often starting with "what if?" They're great for getting at underlying thoughts or feelings someone might not state directly. What if you had 3 wishes? Stuff like that.
And the miracle question. That sounds dramatic.
It is pretty powerful. It's a fantastic goal-setting tool. You ask something like, okay, imagine tonight while you're sleeping, a miracle happens, and all the problems that brought you here are solved. When you wake up tomorrow, how would your life be different? What would you notice?
Wow, yeah. That really forces you to picture what better looks like.
Exactly. It helps visualize recovery and identify concrete goals.
Okay, so those are the key tools to use.
Mhm.
Now for the pitfalls, the don'ties. What are the big non-therapeutic techniques that just kill communication or hurt the relationship?
Well, basically, anything that involves the nurse judging or taking control away from the patient is problematic.
Like giving approval. Seems counterintuitive.
It does, right. But giving approval or agreeing, saying things like, "that was a good decision," or "you're right about that," it subtly implies the nurse has the authority to judge the patient's actions or thoughts.
Ah, okay. And that makes the patient focus on pleasing the nurse.
Exactly. Rather than focusing on their own internal reasons for change, it fosters dependency. Same goes for giving premature advice.
Don't jump in with solutions.
Right. It completely undermines the patient's own ability to figure things out. And minimizing feelings or offering false reassurance, like saying, "oh, don't worry," or "everyone gets down sometimes," that just belittles what they're going through.
Makes them feel unheard or dismissed.
Totally.
And what about the single word, the conversational trap, that makes patients instantly clam up?
The fatal flaw, asking why questions.
Why is so bad?
Because it sounds judgmental, it demands justification, it puts people on the defensive immediately. Think about it. Why did you stop taking your medication? It sounds like an accusation.
So what's the alternative?
Use what, when, where, or how instead of "why did you miss your appointment?" Tell me what things led up to you not being able to make the appointment. It's much less confrontational and more exploratory.
That makes a huge difference in tone.
Oh.
Okay, shifting gears slightly to the actual interview setting. The source reminds us pace is important. Let the patient set it.
Yes, absolutely. You have to adjust. Go slower for someone with depression, maybe faster if someone's experiencing mania, but always follow their lead. And the physical setup matters too, safety and comfort.
Like sitting at the same height.
Yes, eye level is important. And critically, don't put a desk or table between you and the patient if you can avoid it. It creates a barrier.
And for safety.
The nurse should never, ever be positioned in a way where they're blocked from the door. Especially in psych settings, you always need an exit route in case things escalate.
Good point. And we also need to manage our own nonverbals, right? Using attending behaviors. The source breaks this down into kinesic, vocal, and proxemic communication.
That's right. Kinesics is basically body language posture, gestures. Leaning in slightly shows interest. Crossing your arms often signals resistance or closing off. Little things make a big difference.
And vocal quality.
That's the paralanguage, how you say things. Volume, pitch, rate of speech. A soft, gentle tone usually encourages sharing. A rapid, high-pitched voice, that screams anxiety no matter what words you're using.
Wow, it sounds like nurses need this constant, internal radar running, reading the patient, reading themselves. Is that exhausting?
It takes conscious effort and energy, for sure, which is why understanding proxemics, the use of space, the distance between people, is also key. It helps manage comfort and boundaries.
Hall's categories, right? Intimate, personal, social distance.
Exactly. Intimate is very close, 0 to 18 inches. Personal is about 18 inches to 4 feet. Social is 4 to 12 feet. Nurses usually operate in that personal or social zone.
But you adjust based on the patient.
You have to. Someone who's paranoid might need more space. Someone highly anxious might perceive closeness differently. And cultural norms play a huge role here, too. You have to be observant and flexible.
We also can't ignore technology's role now. It's changing mental health care delivery.
Big time. Telehealth is huge. It gets around so many barriers, distance, lack of local providers, even the stigma some people feel about walking into a clinic.
And mobile apps.
Yeah, lots of apps out there now, like the ones from SAMHSA, Suicide Safe for clinicians, No Bullying for parents. They can be really useful tools.
But the source adds a note of caution.
It does. It stresses that we need more research on efficacy, safety, privacy, liability, all that stuff. The tech is moving fast, and the evidence base needs to keep up.
So, okay, we've covered the theory, the DOs, the don'ts, the setting, the nonverbals, the tech. But how do nurses make sure they actually master these skills and keep improving? What about professional development?
Great question. Clinical supervision and debriefing are really vital. They provide that space for critical reflection, talking through tough interactions with a mentor or peers.
And a hands-on tool.
The hands-on tool for really honing skills is the process recording.
What's that exactly?
It's basically a detailed written account of an interview, what was said, verbal, what was observed, nonverbal, the nurse's thoughts and feelings during it, and then an analysis of the interaction.
So you critique your own performance.
Pretty much. You identify what worked, what didn't, where you used therapeutic techniques well, where you maybe fell into a non-therapeutic trap, and how you could approach it differently next time. It's how you bridge the gap between knowing the theory and actually applying it effectively. It's critical for mastery.
Wow. Okay, this has been incredibly thorough. A real deep dive into the nuts and bolts of therapeutic communication. We've really established it's this patient-centered core of safe, effective care.
Absolutely. And it's built on understanding that complex dance between verbal content and nonverbal process.
And mastering those specific techniques, active listening, reflection, clarifying, and knowing what not to do, like asking why, that's just essential.
It really is. Which brings up a final thought, maybe something for you, the listener, to really chew on as you take this all in.
Okay.
Given how diverse our communities are becoming and how vital patient-centered care is, how can healthcare professionals constantly ensure their awareness of their own cultural filters doesn't lead to bias, especially when interpreting those really subtle nonverbal cues like touch and eye contact we talked about? How do we keep ourselves in check?
There's a powerful question to end on. Really making sure our own biases don't become another barrier. Thank you for joining us in this deep dive.
And thank you for learning with the Last Minute Lecture team.